Today, I'm gonna give a talk about the cataract surgery in uveitis. The talk gonna be divided into two parts. The part 1, which is the principle and perioperative management. First, to understand the uveitis cataract, I would like to emphasize of you that uveitis is not a single disease, but it's a group of diseases that share common characteristics with its intraocular inflammation. The outline today, we're gonna divide apart the talk into 4 parts. 1. The indication from the cataract surgery, perioperative management, which is preoperative, postoperative, and special concern. The indication from the cataract surgery, which is visual significant cataract. Significant cataract impair proper access to treatment of posterior segment. Cataract impending posterior segment visualization during vitrectomy and lens-associated cataract. But in uveitis, 2 things must be added. 1. Visual significant cataract with preoperatively controlled inflammation is the key. And the lens-associated cataract with intraocular inflammation, which is the indication to remove the lens to control the inflammation. For the preoperative management, surgical planning is also very important because remember, the uveitis cataract is different in every case. It can be simple or very challenging, like the picture on the right. Backup plan should be thinking before you going to the cataract surgery. Not just only the manage patient, but also you need to manage surgeon expectation as well. Why? Because the prognosis of the cataract surgery in uveitis can be very different in many kinds of uveitis. Such as in the table, the viral associated anterior uveitis that have cataract, the prognosis is usually good with rare complication with high femur and glaucoma. Contrasting with the cataract surgery in some diseases like sympathetic ophthalmia, VKH, Behçet, or JIA, that the prognosis usually depends on how bad of the disease in the posterior segment of the eye. Considering controlled inflammation and probably as steroid and immunosuppressive therapy can be the very important to get the best possible outcome. In terms of inflammatory control, the well-controlled inflammation for treatment is recommended because the CME rate is lower in the case that have well-controlled more than 3 months prior to the surgery. We would like to avoid the surgery in the hot inflamed eye. In the complicated cases that you might need to go in, 3 days to 14 days of oral prednisone, about 0.5 to 1 mg day is recommended. In some cases that patient cannot tolerate the side effect, the local injection and the immunosuppressive can play a role. Intraocular pressure control. It depends on mechanism which cause the increased IOP. But in general, proper IOP control is recommended for at least 2 or 3 weeks prior to the surgery. And if you can avoid that some anti-glaucoma such as anticholinergic or prostaglandin, because that may associate that with higher risk of cystoid macular edema postoperatively. The choice of anesthesia is also important. Topical is possible, but in case of you need to manipulate the iris, that can cause the pain. And no pain surgery is the key. You can choose intracameral, posterior subtenon, retrobulbar, peribulbar, or even general anesthesia in case of you need to manipulate the iris, and that can cause the pain during the surgery. Recent postoperative management is also helpful. You can consider adjunctive intracameral beta-dexamethasone, subconjunctival dexamethasone, which is work very well, but remember, it's going to be in the eye for less than 24 to 45 hours. Subtenon thiamcinolone can be used. Intravitreal injection of the steroid many form and intravitreal implantation can be used adjunctively. Intracameral antibiotics can be another thing that to prevent the postoperative endophthalmitis. And overall, long-term, regular, and reasonably frequent postoperative follow-up with prompt treatment are essential. Some special concern. People talking about the antimicrobial prophylaxis in case of infectious uveitis that you need to go for the cataract surgery. Unluckily, we don't have the rigid guideline. All of these are controversy with limited evidence. But some are recommended in the literature, like toxoplasmosis prophylaxis, even by the systemic bacterium or the intravitreous clindamycin. In the viral anterior uveitis, in the herpetic group, herpes simplex, herpes zoster, CMV, antiviral can use both systemically and locally, like intravitreous ganciclovir, like shown in the skin. Uveitis is not a single disease. Know your patients, not only the eye. Adequate inflammatory control, and recommend for 3 months preoperatively. No pain surgery is also a key. Always have plan B, and long-term, regular, reasonably frequent follow-up with prompt treatment are essential. And we're going to have the second part of the cataract surgery in uveitis, coming up with the intraoperative challenges, how to manage the uveitis cataract in the second part. Thank you.